Welcome back to Health Matters. Today we're diving into the world of allergies with Professor Mike Levin, a leading expert in asthma and allergy at the University of Cape Town. Now, as the head of the Allergy Foundation of South Africa, he's dedicated to providing vital resources for both doctors and patients. Over 150 scientific publications and contributions to key medical textbooks, Professor Levin has played a crucial role in shaping national allergy policies and, of course, guidelines as well. Now, in this episode, we explore the rising prevalence of allergies in South Africa, what's causing it, the biggest challenges, and, of course, how we can manage conditions like asthma, food allergies, eczema, hives, these things more effectively. We also discuss where to find reliable information and the best support available for patients. Now, whether you're living with allergies or supporting somebody who is, this episode is packed with expert advice to help you breathe easier and live better. Welcome, Prof.
Hi, guys.
Hi, good to have you with us now. Prof, let's start with at the very beginning. What are the major allergies people in South Africa face?
I think you've already mentioned some of the major allergic diseases, and that's a good place to start because we can cluster the different allergies people get to individual substances depending on what kind of area of the body is being affected at the end of the day. So we've got patients with asthma and rhinitis. Those respiratory conditions are predominantly caused by indoor and outdoor airborne allergens. Then we've got things like atopic dermatitis, where you can have reactions to dust, but also in very rare settings, it can also lead to IgE-mediated food allergy. So the whole area of food allergy, which is the immediate type reactions that people get like peanuts and hen's eggs and things like that. We've got that entire range of different allergens. So what's really interesting about allergies is not only do the allergens vary between different diseases, but they also vary between different individuals. And every person with allergies is actually allergic to different things to a different degree.
Now, Prof, where can we get information, reliable information? We live in this era where it's so easy to pick up, and Dr. Google seems to be the go-to for many households. But where does one find good, reliable information about allergies?
So Dr. Google is not actually a good place to get information about allergies because there is so much misinformation out there. And that is really one of the reasons that we started the Allergy Foundation of South Africa, is because we wanted to have a central hub that was trusted by patients and curated by medical people with an interest in their patients, so that that can be the site where people can get reliable information that is unbiased and is not, trying to push a particular pharmaceutical drug or a particular homeopathic cure or a particular type of investigation that you will find on the internet that, we don't believe are reliable. There are lots of opinions about allergies. Every single person, including your aunt and your grandmother, will have an opinion about your allergies. And I just make a plea. Go to the experts. Go to www.allergyfoundation.co.za. We've got a huge amount of patient information. We've got newsletters that can be sent to patients. We've got resources for both patients as well as the doctors to download and use. About, inhalation techniques for the spacer devices, or how to use your ointments, or why you need to take your oral antihistamine for urticaria every single day rather than as required. All of that information is online at the Allergy Foundation. And the amazing thing that we do beyond that is we have patient support groups. So we've got a food allergy support group, and we've got an atopic dermatitis support group. So there's plenty of scope for people to get involved in our resources, but also our patient advocacy measures.
You're spot on. As you were telling us and talking us through that, I couldn't help but think about all those people that self-diagnose in my own family, that at certain times of the year, whether they think it's the season or the pollen count or whatever, they know that this is what's causing them to react the way they do, and without going and seeking any kind of professional advice themselves. So you've kind of hit the nail on the head there. Prof, what patient support is available for people with allergies?
So we've got this really great Facebook network of people for atopic dermatitis. that is run by Dr. Sureta Kannenberg, who's at Stellenbosch University. She's the workforce behind that group. And we have regular Facebook Lives and other interventions that talk about how to manage eczema as effectively as possible and trying to get the patient perspective also highlighted. We've got a workshop that will be coming up in August, along with the Allergy Society Congress that will be held in Gauteng. And we're doing a patient and healthcare provider joint session there, where we're kicking off with the latest in the medical advice and the actual way that eczema works, predominantly aimed at the doctors. And then in our afternoon session, we'll talk about some of the new treatments and also about how to advocate more strongly for medications, particularly those medications that funders don't necessarily always want to pay for. So these are the kinds of activities that we get involved in patient advocacy. With the food allergies, we've been instrumental in changing national and local policy. We've got a very good guideline on food allergy in schools that really does lay down the way that schools are obliged to respond to people who've got food allergies under their care. And, that advice that we've fed back to the Department of Education has now been adopted as official policy. But there's still gaps, and there's still hundreds of projects and ideas that we'd like to do. And we're always looking for people to help us. So if they're patients or people who want to get involved and start an allergy at schools campaign at the beginning of each year, that's a project that we've really wanted to do for a long time, but we just haven't had capacity and people to, rely on. So there's plenty of scope for people to get involved and get more information about the projects that we already have.
Professor, you mentioned medication, and again, we look at key tips maybe for management of asthma, food allergies, eczema, or hives. What are those key tips for the management of said asthma, food allergy, eczema, and hives?
Okay, so I'll have to take them one at a time because clearly they're all different conditions. Yes. Let me think. My top tips for eczema is to realize that the skin itself is the problem in 99% of patients, rather than something outside the body that is affecting the skin. And the fundamental importance of that is that you need to use your emollient therapy all the time, every single day, to restore that skin barrier, because no other medications you're going to take is going to prevent further damage apart from emollients. That's the basics of treating eczema. Second thing I'd like to say about eczema is don't be afraid of using topical corticosteroids. When used at the correct strengths and for a normal amount of time, they do not cause major problems. And in fact, when the skin is inflamed, they're your absolute best friend. Mm-hmm. Importantly, with eczema, most people will need some kind of maintenance treatment that is anti-inflammatory as well as the emollient. So using topical corticosteroids once or twice a week as long-term maintenance treatment also cannot cause skin damage. So that is kind of like the maximum that we want people to be on long-term. And then my final points are, if people are literally failing the therapy with topical corticosteroids alone, do not be afraid to move on to systemic therapies. And there are systemic therapies that are the small molecules that are still available and are very effective, like methotrexate and cyclosporin. And there are also, newer drugs that are injectable or oral that are extremely effective for the very, very severe forms of eczema. So I think those are my top tips with regards to eczema.
Okay.
What should we do next?
Food allergies, eczema, we've done asthma or hives.
Okay, so let's talk about hives. I think hives is a condition that is very much underappreciated by patients. They seem to think that it's an irritation, and then it can settle down and become like it'll go away. And in fact, many episodes of hives that we see in both children and adults are not the acute hives that you see, that you get them for a couple of days and they go away. People get what is called chronic urticaria, where it lasts for, by definition, more than 6 weeks. And chronic urticaria, on the other hand, has a huge impact on people's quality of life. They're itchy all the time and they can't concentrate and they have disruptions of their social activities and their work and all sorts of other things. So the importance with chronic urticaria is it should not be treated just with as required antihistamines. It should be treated with the new non-sedating antihistamines, and those antihistamines should be taken every single day for at least the first 6 months. And then after 6 months, if you wean them off, the urticaria might have gone away. It might have been suppressed by then, or it might have continued, in which case you just continue for another, another 6 months or so. The important thing with this condition is that you have to use antihistamines at very, very much higher doses than those that are usually prescribed for just quick urticaria or for nasal symptoms, up to 4 times the normal dose that is used for hay fever. And for that reason, it's 100% necessary to use a proper non-sedating antihistamine that can't cause any problems whatsoever. I know that the sedating antihistamines are cheaper than the non-sedating antihistamines, but they should not be used for more than about 5 days in a row. Otherwise, they start having side effects. So key messages for urticaria is regular controller therapy. Don't underestimate it. Get it under control and make sure that you avoid, like the plague, any of those sedating antihistamines.
All right. Key tips for managing asthma. Let's go there next.
Sure. So asthma is, I think, one of my favorite conditions because everybody thinks they know how to treat asthma and very few people actually do. And the great thing about asthma treatment is that the tips that you give your patient can make the difference between them having a completely normal life with no impairment, no tight chest, no nothing, or just continuing on having symptoms all the time. So patient education and training is really, really critical for asthma. I think my key points would be asthma is at the basic level a disorder of the chest where there is inflammation. I know that everybody notices the spasm and the tight chests that come on acutely as being the most important feature for an acute attack of asthma. But even that comes because that underlying inflammation is not controlled. And that is why all patients with asthma need regular controller therapy. They need to be on some kind of an inhaled corticosteroid, except for the extremely, extremely mild forms of asthma, or in young children, the situation where you're not actually sure whether it's asthma or not. But pretty much every person who's listening, who thinks they've got asthma, if you are using just a reliever pump alone, your asthma is not being treated according to our latest guidelines. It's a problem to be using just a reliever and not any anti-inflammatory. In fact, it's dangerous to do so, and your risk of having acute attacks and landing up in hospital and even dying from asthma are higher if you're using just a short-acting beta-2 agonist and nothing else. So that's the main point. The first point is inhaled corticosteroids are the fundamental treatment for asthma and essentially nothing else. Second point I want to make is that oral steroids are rescue therapy for severe exacerbations of asthma and do have side effects. So if you are taking multiple courses of oral corticosteroids, even more than once or twice in a year, then you are not adequately controlled as your underlying therapy, which means you need more of the regular controller therapy to your lungs instead of relying on taking those pills all the time. Prednisone tablets are an emergency treatment. They are not something that people should be relying on regularly. And then the third and final point I want to make with asthma is that because you need to get those medications into the lungs, you need to choose the device that is suitable for you and use it with the best possible technique that you can use it to get that medication into the chest. And there are different types of medications. There are dry powder inhalers that you have to suck hard in to get the powder into your lungs. The more commonly used medication for asthma is an asthma pump, and that asthma pump should preferably, with all patients, definitely all children and all adults with, moderate to severe or kind of asthma on a combination therapy pump, they should all be using a spacer with their pump to allow that medication to get into their lungs. If you use a spacer and you put it in your mouth, most of it just goes into the back of your throat. It doesn't go anywhere near where the problem is. So using a spacer with the best possible technique is critical for the use of your asthma pumps. And in that, you need to not only select the right medication and the right pump, you also need to select the right spacer. So I just want to correct a misconception that is out there. People think that all children who are using a spacer should be using a spacer with a mask. And that's not correct, because a spacer with a mask causes the deposition, instead of going to the back of the throat, to go a little bit more against the face, and then some of it does go down the lungs. But as soon as somebody is able to put a spacer in their mouth so that they can take at least that little shortcut, that deposition to the lungs is much better than using a mask. So lose a mask on your spacer when the child becomes maybe over the age of 3 or 4 at most. As soon as they can put it in their mouth, a spacer without a mask is a much better way of getting medication into your lungs.
Well, that's an eye-opener. My daughter's 8 and she's still using the one that goes over her nose. So there, I've just taken away a pull from that, Prof. Then let's finally talk about food allergies. What are the key tips for managing food allergies?
Okay, so food allergies can range between something that is quite mild and an irritation where you have a little bit of tingling of your lips and your tongue after you've eaten quite a lot of that particular food, all the way to the other side where you can have like a tiny little trace of any food, really, and it can cause a very, very severe reaction. So food allergy is a spectrum of severity. That's one of the most important things that I think people need to recognize. The second thing that people need to realize is that food allergy testing tests for what we call sensitization to the food. It tests for the antibodies. And if those antibodies are not there, the level is 0, then you cannot have an immediate type food allergy, that immediate life-threatening type of food allergy that I'm talking about to that particular food. Right? It doesn't exclude a different type of food allergy that has different mechanisms, but that immediate severe life-threatening type of food allergy is excluded. On the other hand, if there are some degree of antibodies in the blood shown by an allergy test or by a skin prick test, that does not mean that you have food allergy to that food. It just means that it is possible that you have food allergy to that food. And it's the job of a well-trained pediatrician, internal medicine person, or an allergy specialist to look at those numbers that come from those laboratory tests or from those bumps on the skin, and then interpret those results along with the history of what the patient tells you in order to make a decision. Can I decide, is this person definitely not allergic? Is this person definitely allergic and they must avoid that food? Or am I still not sure? Because there is quite a large middle range where the combination of those tests and the history can't actually answer that question. And in that situation, what we have to do is called an oral food challenge. And you can get more information about this on our website, in which we give the person a tiny little bit of the food at 15-minute intervals under very close medical monitoring, of course, in case there are any reactions, and we see what happens. And the outcome of a food challenge could be that you eat the food and you're fine and you have no problem. Or you could have your very, very first dose and have a bad reaction. Or you could go all the way up to the 4th, 5th, 6th dose and have a mild reaction. So even in the situation where a patient is failing their food challenge, they still get very useful information. How scared do I need to be? How cautious do I need to be? Do I need to avoid things that may contain labels on them? The fundamental point that I'm making is that to actually diagnose food allergy properly, You need to be very familiar with those laboratory tests and how they work. And you need to be able to do food challenges if you cannot get your final answer. So in this particular area of medicine, it's actually so specialized that if you're being seen by somebody who doesn't have the ability to do a food challenge, if they're uncertain, it probably means that they're not the right person to diagnose immediate type food allergy, because they would have to then send you to somebody else in any case, in that vast majority of cases where you cannot make that final decision. The third point I want to make about severe food allergies is that carrying your adrenaline auto-injector with you at all times is absolutely critically important. And what is also important is that the school teachers for kids or the other carers for the children need to be educated about when and how to use the adrenaline auto-injector. And with respect to schools, they need to take responsibility for the children under their care by keeping them safe with that safety net, not be lulled into a false sense of security that we are going to make our school peanut free, which will never work and is actually impossible and has been shown not to actually be enough to keep children safe. Rather, let people eat what they want in the school, but make sure that your staff are taught how to recognize anaphylaxis, that every single child with a chronic condition, regardless of what it is, whether it's epilepsy, whether it's ADHD, whether it's diabetes, whether it's asthma, that you have one of the education department's specific forms filled out for chronic diseases that says, this is what I must do to keep this child safe under my care at school. And get that aspect of the safety sorted out rather than the, I think, less important and distracting issue of who should be eating what where.
Sure. This was so insightful. Prof, thanks so much for your time. This has been an incredible episode chatting about a whole variety of things. So, Prof, thanks for your time today.
Pleasure. Wonderful to be there. Please, guys, feel free to look at the website or email info@allergyfoundation.co.za. There's plenty more resources available out there, and we'd love to hear from you and have you as part of our team going forward.
Thanks so much, Professor Mike Levin, with us today. Episode brought to you by Allerset. Now, Allerset is your syrup and tablet solution available without a prescription, indicated for allergies, fever, like hay fever, for example, and allergic skin conditions as well. Be sure to like, subscribe. We're on YouTube. We're all over the place. It's Health Matters SA on YouTube. Check us out. We'll be back with another episode next week.